So you have to have a fine cut CT scan to do it. You can't do it with a screening CT scan, and it's really disappointing to have to tell a patient, sorry, I can do a safer surgery if I use image guidance, if I want to do that, but we're going to have to get another CT scan. So if you can go ahead and incorporate a fine cut CT scan into your practice, that would be helpful for all of us. And again, essentially the same amount of radiation.
If we send them to you, can you use image-guided CT from our clinic, take that disc in, or do you have to do it at the U?
Yes. The question is, can I use a fine-cut CT scan from other institutions? The answer is yes. Yeah, the only one I can't use is the Zoran, which is the in-office CT scan that some people have. For whatever reason, it just doesn't function. Probably because it's scanned in the coronal plane. You have to have true axial cuts for the image guidance to work.
Now that we're recording, you want to start over again?
And conclusion.
I always look at all three planes. The coronal, the sagittal are super important to figure out the coronal outflow tract and the axials, and that's what you get. But here's the alternative. Beautiful sinuses. Again, 18% of the patients I see with chronic sinus disease have CT scans that look like this. And I always ask the patient, I'm saying maybe. It's either yes or no. If it's I don't think so or no, come back when you got your symptoms. Come back when you know you need antibiotics, because I want to make sure that we're getting the right diagnosis. I can't stress this enough. There's a reason our academy in 2007 changed the diagnostic criteria for chronic sinus disease to mandating we had either CT evidence or endoscopic evidence of chronic sinus disease to make the diagnosis. We were doing too much surgery, over-operating on patients, giving too much antibiotics and steroids on patients, 18% of them with healthy sinuses. So other things that can be TMJ disorders, dental problems, acid reflux causes everything, migraines, and then facial pain and headache disorders, and that's the number one culprit. When to send a patient to us anytime you want is a good answer, but when they don't get better, when they have recurrent sinuses, so recurrent acute sinusitis, well, that's a whole nother talk right there. What do you do with a patient who gets 4 or more infections per year? They get better with antibiotics. We used to say, sorry, there's no role for surgery. At least most of us used to say that. And now there's some evidence that says if we do some minimal sinus surgery to the maxillary and anterior ethmoid sinuses, it does decrease the frequency of their sinus infections. Balloon sinuplasty may also be a role, but I caution you, we've got to make sure that we're operating on diseased sinuses. The balloons were overused, probably still are, on patients without active sinus disease. And so when I'm considering those types of therapies, I always have to have at least one CT scan that shows a sinus infection. Medicine versus surgery, what's better? Well, if you believe the Cochrane collaborations in 2004, this is the only study that cut the mustard. They looked at 327 patients. The interesting thing, 60% of patients they approached for this study, 60% said, no way, I'm not going to get randomized to surgery or medical management. That's crazy. What about the 40% who agreed to enroll? Were their symptoms as severe as those 60% who refused? We like to think not. It didn't publish the patients who didn't enroll, but they showed no significant change in outcome between the medical versus surgical cohorts.
I assume that didn't include those who had already failed medical therapy, or
that randomized people at the beginning to medical therapy. They did have a trial. I believe it was 2 weeks of antibiotics and 2 weeks of a nasal steroid spray before randomization. This study was done by a group of otolaryngologists, so you already know there's a bit of a bias there. This was published in IFAR just 2 years ago, and it was 100 patients. 1/3 of them were in the medical cohort, 2/3 of the surgery cohort. And on the blue line, that shows the surgery cohort. They did improve more than the medical cohort after sinus surgery, 12 months out. 1/3 of the medical cohort, this is the dashed line down low, 1/3 of them said, forget it, we're crossing over to the surgery arm. And they did about as good as the medical patients. So this is the best study we have, which still is not a true randomized study. I don't think we're ever going to have a true randomized study. It's just when patients come into you, when patients come into us, they have their own bias of what they want to do. And we're not going to, even ethically, someone comes in with horrible disease, horrible symptoms, they need surgery, they failed medical management first. You always have to try medicine first unless you're concerned about cancer, tumor. But I just don't ever see us answering the real randomized question. The goals of surgery, this is important now. Removing the obstructing lesions, getting rid of the polyps. That's the goal. Making small openings to the sinuses larger, a lot larger, so that topical therapies can get in, the pus can drain out, and then you can clean them out in clinic. Teal has, his group sends a bunch of patients with cystic fibrosis to me. We now do these things called mega maxillary antrostomies, medial maxillectomies. We remove essentially the whole medial wall of the maxillary sinus, simply to facilitate when they fill up with staph and Pseudomonas, simply to go in clinic and the topical therapy and just scoop it out. It's really easy. I think it helps. There's data to support that it helps. So that's the surgery that we do.
There used to be this diagnosis of empty nose syndrome when too much nasal tissue was removed. What's your comment about it?
Correct. So the question is about empty nose syndrome, and it, Dr. Price, right, it relates to the turbinates. We try to leave, if we're doing an endoscopic medial maxillectomy, we leave the front, the head of the inferior turbinate, back part. That seems to be enough. Empty nose syndrome is when you completely take out, you almost take out everything. Middle turbinates, inferior turbinates, and people are left then with a dry, crusty, congested nose. You look in the nose, you can see all the way back to the nasopharynx, but it's dry and full of debris. That being said, it's still a syndrome. I've seen a few empty nose syndromes over the last 8 years. I've never met someone with empty nose syndrome that doesn't have an anxiety issue. There's always something on top of it. And it's tough. There's one person in Minnesota who specializes in empty nose syndrome. There's some treatments we can do. We can put fillers in the residual turbinate or the septum. But it's a tough thing to fix. And it's when people when they have empty nose syndrome, they say, I feel better when I have a cold. If that's the case, then we can fix that. But the real idea is not to get it in the first place. The most important slide of the day is what I tell all of my patients before surgery. The day we cure your asthma is the same day we cure your chronic sinus disease. And that is the basis of my discussion with my patients. It's setting the expectations up right. We're not fixing the underlying root cause of whatever in the environment or genetically is causing their reactive airway disease. It's a treatment. Albuterol is a treatment. It's not a cure. It's the same idea. This is a case that just kind of talks about the surgery side of things. And this is someone with sinus disease without nasal polyps. This is intraoperative, patient's under general anesthesia, and I'm putting a little probe right in the left maxillary sinus. And you can see this purulent material just coming out under suction now. That's what I see when I do surgery. It's kind of gross, but my staff love it. Right now I'm touching the lining, the mucosa of the maxillary sinus, and just opening it up a little bit. You can see how thick and diseased it is. And how can inflamed tissue like that, how can it have any immunity against the infection there? Literally, you have to go in and scoop it out. That's how thick it is. And it's really fun when I have medicine residents who are watching, and they come in and they say, oh yeah, now I understand why antibiotics work. Here's more taffy coming out of an ethmoid sinus. It's true. Yeah, it's amazing. It's rewarding, but kind of gross at the same time. So surgery, it's great to help penetrate for topical therapy, as we talked about. Getting back, topical antibiotics are not recommended at this phase according to our expert guidelines. That being said, we're using it. There just aren't great studies. I'm going to show you. There's a couple studies. So P.J. Wormald is my mentor. I trained with him in Adelaide after residency, and his group, they looked at this is a really short study, 22 patients did a randomized trial who had staph in their sinuses after sinus surgery, and they randomized them to saline irrigations versus piercing irrigations. All of the patients randomized to saline irrigations, culture positive 1 month later. Only 1 out of 9 patients who randomized to piercing irrigations, culture positive for Staph aureus. So this helped. There's also a huge rise in piercing resistant Staph aureus in Australia, where Professor Wormald works and where they're doing a lot of it, and New Zealand as well. Yes.
Did you see any anosmia when you did this? Because when I did this, my old mentor, Mike Kellner, said he stopped doing this because the patients started all complaining of anosmia.
We're going to talk about anosmia. That's a great segue.
Sorry.
2 slides away. They did a longer follow-up study at 6 months out. At 6 months, culture, only 27% had a cure. So 72% of these patients, the Staph aureus returned. And that's exactly what we see clinically too. So topical piercing irrigations, I think it is something that can be used. It's hard to get rid of the staph though. Antifungals, we don't recommend. So anosmia, it's interesting you brought that up because we did a study looking at the old Zicam, which was taken off the market back in 2010. Really quickly, it was a zinc-based over-the-counter remedy to treat cold virus, and there was concern about anosmia with it. So we took tissue that, I harvested tissue during sinus surgery. We would run it up to the lab, culture it, and apply different topical medications to it. Rhinocort, Zicam, Afrin, a few others. LDH, this is the levels of LDH. LDH is released when the cells die. These are days after harvesting. All of the medications we tested didn't have any impact on cell death except for Zicam. Zicam, this is a saline-treated tissue. You can see a nice basement membrane, nice epithelium. This is the Zicam-treated tissue. It just causes tissue necrosis. It completely destroys the epithelium. The FDA pulled it from the market. There were multiple lawsuits, class action lawsuits, and even even the stakeholders who had stock in Zicam sued their own company because Zicam didn't report the adverse events of people having anosmia to the stakeholders, and the Supreme Court upheld that.
Wow.
It's sold in other formulations?
Yeah, so Zicam was bought out by J&J, and now they have menthol, they have an Afrin version of Zicam, they have a eucalyptus version. It smells great, it tastes nice, but
Well, they took the zinc out.
they took the zinc out. Yes.
Clever.
So anytime I'm using these medications off-label, I mean, people come in, they use hydrogen peroxide, tea tree oil. There's so many things that people concoct. Silver solution, I always talk about this is off-label. If I'm recommending it, sometimes I get informed consent. I give them clear instructions if I'm doing some strange things like topical budesonide. I have an instruction sheet, Manuka honey, things like that. And I always tell them, if it hurts, stop. Don't do it. Another case here, 52-year-old female, no comorbidities. She had non-inflammatory sinus disease, prior sinus surgery 4 months ago. She had this thing called an oncocytic papilloma, which isn't important for this talk, but she continued to have facial pressure and thick nasal drainage. And this is a type of patient that is so challenging to treat. On endoscopy, all sinuses are open. Again, that's the number one goal of surgery, other than do no harm, is to open up the sinuses. Her sinuses were wide open. But she had thick, purulent debris. No surprise, it was Staph aureus. She didn't get better with sulfa. She came back, and I had to take out the oncocytic papilloma anyway, and she's actually from Everett. This is what she looks like intraoperatively. Ethmoid sinuses, there's a little bit of pus in there. But here's the maxillary sinus, just a non-functioning sinus. It's wide open and full of pus. This is on the left side, and this is high-powered suction, and you literally just have to pull it out. So that's the challenge. You have an open sinus, and it's full of Staph aureus. What do you do? We're working on an answer. You just pull out the kitchen sink is the answer, and work with the allergist to make sure, and the immunologist to make sure that you're doing culture-directed antibiotic therapy. Make sure their immune system is functioning appropriately. We've picked up quite a few CVIDs in the past couple of years. Sometimes we use a povidone iodine irrigation. We actually have a 3-arm trial looking at povidone iodine versus piercing irrigations versus saline right now. And the preliminary results look like they're all about the same. They all cured the staph at 1 month out by about a third of the patients. And then there's these biofilm busters. Manuka honey, I use it maybe once a month in some of my patients. It's safe. There's good Manuka honey, there's bad Manuka honey. There's never been a good human trial on it. There's been a nice trial in sheep with, that they give sinus infections to, and Manuka honey seemed to work. And then photodynamic laser therapy. This is something that's approved in Canada. It's not approved in the U.S. yet. It would probably be helpful in the trial. And it uses essentially laser energy and makes free radicals by stimulating methylene blue to address that sticky biofilm and pop holes into the bacteria. The people I've talked to in Canada love this thing. Part of it, though, is the Canadian healthcare system. It takes about 1.5 years to get in for your sinus surgery. So they do a lot of other clinical type procedures, and this is one of them. The final case, which many of you have seen, is an interesting case. Before I get into this, any questions about nasal polyps? This is for entertainment stuff.
Not polyps, but do you ever open up the maxillary sinus and have these people drop catheters in there so they can irrigate their own sinuses when you get into refractory staph? One of our Everett surgeons used to open up and give them these little pediatric Foley catheters and teach them how to drop it into their sinus.
Yeah, we have not done that, and there's really not many people that are doing that. Every now and then, some bring that up. For those listening, the question was, do I put in a catheter so people can self-irrigate? The irrigation alone doesn't get it out. If you have that maxillary sinus that's wide open, full of thick pus, even if I squirt saline in there, it doesn't get it out. You have to use suction to get it out. It's that sticky. And
do you have anybody that will let you use N-acetylcysteine to irrigate with instead of just saline?
Yeah, using N-acetylcysteine as essentially a mucolytic. I've recommended it a couple dozen times in the last year. Tends to work in the lungs. You guys deal, right? You use it sometimes.
Yeah, I mean, there's probably newer generations of the same kind of thing as N-acetylcysteine that eventually will work as mucus-reducing agents. But we always worry about N-acetylcysteine because it causes bronchospasms. So if they, if they get it in their airways. But there's actually, as a grant reviewer for several of these studies, there's some very promising products that will work as mucolytics.
The only problem is Pulmozyme's so expensive, and the insurance won't let that go with anybody that doesn't have CF. So you can never get approval to use Pulmozyme.
Baby shampoo?
Baby shampoo. So my friends at University of Pennsylvania were using Johnson's baby shampoo for patients with cystic fibrosis. And this is about 8 years ago now. They showed some beautiful pre and post photos 6 months later. It looked great. It was a surfactant in Johnson's baby shampoo that they liked. And so they developed a company called Sinusurf, which is a surfactant. And NeilMed bought it out. 6 months after it was on the market, they pulled it because a few patients complained of anosmia. All the patients with cystic fibrosis, none of them can have a good smell function anyway because of their disease. And I do use it on occasion. The Johnson's baby shampoo, it's 2 drops to a sinus irrigation bottle. But again, it's not supported by any good evidence. And I always warn them about anosmia.
I think some of these people have a chronic, non-infectious inflammatory disease, and I've treated some with cyclosporin and methotrexate, which is pretty punch, but clinically, just empiricism, I think they get better. They get better.
I think you're right. I think most of these patients have non-infectious inflammatory sinus disease. I completely agree. It goes along with these. We have some very complex hyper-eosinophilic patients. They're super challenged to treat. You give prednisone, they get better. Prednisone without antibiotics, they get better. Methotrexate, cyclosporin, they get better as well. So often we have, it seems to be a group of rheumatology, pulmonary, allergy, immunology, and otolaryngology that will bounce emails around about these particular patients.
Is there a role for chromones?
For cromolyn?
Yeah.
Cromolyn, the mast cell stabilizer.
Sort of.
You guys know the answer to that more than I do. I use cromolyn if I'm going over to a friend's house who has a cat. It works great. But I don't routinely use it for my allergy.
Yeah, sure.
Greg, I had a recent run of a bunch of hyperosmia patients, like non-congested, non-allergic. Do you deal with
hyperosmia?
Like
Super smokers.
Yeah.
Yeah.
Like,
There hasn't been any good research studies on that. A couple of us have talked about doing it. Sometimes it's annoying. Is that why they present? Or?
Treat him with Zycam. Fix him right
The
up.
real sad story with Zycam is we finally, through all these litigations, finally got the scientific advisory board meetings from 2004, and their own scientists showed the slides of mouse models and how it destroys the olfactory epithelium. And they presented it to their scientific advisory board, and the patient or the company continued. So it was disturbing. Yes.
There are many folks with autism who have super sensitive smell. Any connection that you've seen?
Yes. So we have a study, NIH-funded study right now that is looking at people with autism spectrum disorders, and we're taking cell samples from inside the nose, looking at cyclic MP levels to see if that makes a difference. And potentially, we think it will. We think they have higher levels of cyclic MP, so that may be some medical modulation.
What would you treat them with? How would you deal with it?
Well, if it's high, I don't know. If it's low, we treat them with a phosphodiesterase inhibitor. It's not going to be low; it's probably going to be high. But that's also so related to anosmia or hyposmia. There's a drug, theophylline. You guys have used it from time to time. Theophylline was an oral drug or is an oral drug. Lots of toxicity and interaction issues, but a company has developed an intranasal spray version of it. We'll probably be doing the clinical trial at the university starting in the next year.
Do you guys even remember theophylline? Did you ever hear about it?
I heard of it. I never put anybody on it.
We have 6 minutes. Does anybody want to hear about this last case? Or
Sure.
Okay. Some of you have seen this already. I'm going to have to give a 6-minute version, which is tough. This consult took me to the zoo. And here's the patient. His name's VIP, stands for very important primate. He's a big gorilla. He's the alpha gorilla. And he had a bad sinus infection. There's the snot coming out of his nose. He's grumpy, too. And this is what it looks like when you go back to see him. It's myself and Alpha Lel who volunteers his time. He's an otolaryngologist and volunteers his time at the zoo occasion to occasion. This is a picture I took. You can see the thick snot coming out both nostrils. These are the pathogens that the vets cultured out over the 3 months they called us. Started off pretty simple, and you can see with antibiotic therapy, they selected out more virulent pathogens, finally down to E. coli. But he does eat his own poop often, and so it's not a surprise. We came in and gave recommend Cipro, prednisone, just like we would do. We weren't overly concerned about tendinitis. Asked them to do sinus irrigations, and they said, "You do it first."
Interns get that.
But he got really sick really fast. And one of the board members of the zoo, he's a radiologist, Rob Liddell, and he is a partner at the Center for Diagnostic Imaging up by Northgate. So by ambulance and police escort, they took VIP to the CT scanner. This is him on the scanner. I did a nasal endoscopy, caused quite a nosebleed, which was unfortunate, but fixed it. Took an endoscopic collected culture, and that was the time we got E. coli and got the CT scan. Here's his CT scan. He's got a lot of maxillary disease, frontal disease. He's got this big frontal bar compared to humans where we don't have that frontal bar. We have larger frontal sinuses. His ethmoid sinuses were completely opacified, as were his sphenoid sinuses. What's really neat is you look at on this frontal view, this sagittal crest, where all of the big temporalis muscles connect. And inside, there's his brain right there. And it's a good thing that ours is bigger than theirs. We would be in the zoo. Out here, their talks. But he, as I said, he was sick. He became lethargic. He wasn't eating, wasn't drinking for about 3 days. He had erosion of his maxillary wall on both sides, and his whole face swelled up. Also had some skull base erosion. This is Kiki, who's a gorilla that died about 15 years ago. And just in comparison to our skulls. It's kind of neat to see the similarities. The deviated nasal septum, the inferior turbinates, it's exactly like ours, it's just a little bit different dimensions. This is what he looked like before surgery, and really sick, very, compared to before, very swollen face, not eating, drinking. And the discussion was either to euthanize him or try surgery. Hadn't been done before on a gorilla. They asked me, and I was very optimistic. A lot of people cautioned not to do it, but went ahead and did it.
This is hospital up at the zoo.
This was at the zoo operating room. This is him with image guidance, and we brought in all of this high-tech equipment to the zoo, so that was just like our operating room, all the same equipment. This is Dr. Helmick, one of the vets, intubating him with looks like a garden hose. And a strange thing, this is his nose, and you can see how floppy it is. I can pull it out almost 2 inches from his face. And it made it really challenging to get rigid instruments in his nose. That's why it caused the nosebleed at the CT scanner, because I didn't recognize that. So I knew going into surgery I would have to do something different. This is him in the operating room. It looks like just your normal sinus surgery at the UW hospital, except for you look down, you see curling hair, and the smell. Oh, these guys stink so bad. It's a cross between a skunk and marijuana. In fact, a couple weeks later, I took my wife and kids to meet Vip, and we're walking up there. My wife in the gorilla house, she goes, "God, is someone smoking marijuana?" That's just the male gorillas. This is Dr. Collins. He's the head vet. And I'm going to show you just a couple shots in here of what his debris looked like. This is looking in his left nostril, really inflamed, and just nasty, nasty pus that I had to clean out. I mean, it's just pretty horrific. And I'm going to skip that. This is him waking up. Somebody actually has to pull the breathing tube. It wasn't me. And post-op, you see signs like this: danger area, stay away. This is the backside of the gorilla house. And post-op day 1, he was doing great. His facial edema had decreased. He was eating. This is the vet feeding him grapes. And then post-op day 3, I got a phone call, something's wrong. Vip's not doing good. And he wasn't. He had his facial swelling had completely came back. He fistulized. You can see under his mandible here, this is a big fistula. He also fistulized up by his orbit. He was, at the time, on augment. We cultured out augment-resistant E. coli, put him on Cipro, and he started to do better. This is him. Some of you have seen this. You're looking at pus coming out of his right orbit. Wait for it. Dr. Ant never gets old, does it? So after that, he started to get better, and probably because he fistulized. The infection that had spread from his sinuses to his soft tissue started to escape out, and with nothing else other than good intramuscular antibiotics that the vets had to guard him with, he got better, and his fistula closed spontaneously. I was on vacation, and I was supposed to come and post-op check him on day 5. I had to cancel my vacation to do the surgery, and so we were doing kind of a staycation with the kids, went horseback riding, and I came straight from the riding horse to Vip. And when I see him, I always sit down on a stool, and he pounds the cage, and that's how he expresses his dominance, which is fine. He is. But this time he threw straw at me, and I was like, wow, hey, at least you're feeling better. And then half a second later, he threw this hot, sticky and no kidding.
Cougar fan.
And then exactly, he's a Cougar fan. And then no kidding, he right in front of me laid another big pile of gorilla food, and he just looked at me. And I know he was saying, "You want another one?" So I wiped off and I went back to the car and I said, "Hey, Ann, does anything smell funny?" And she's like, "No, but you got something on your ear." Sure enough, I had missed a spot. That's all E. coli gorilla food. Yeah, I love it. 2 weeks later, he was doing much better. I got to feed him monkey chow, which is the little nuggets you see there, and he ate a bunch of organic fruit, which is fun. And this is about a month after surgery. His nose was back to normal. His face was back to normal. He went outside. He got in an altercation with the female gorillas, and he had a fractured canine, so they were planning to take him back to the OR 6 weeks later. I wanted a second look. the altercation, the backstory is because he wanted to have some relations with one of the female gorillas who didn't want it and said no. And all the female gorillas ganged up on him and beat him up.
That's a very social animal.
Yeah, so this is a very quick shot. I know we're out of time here. We're almost done. Give me 1 minute. This is what he looked like. Still a bit of infection. He's still on antibiotics at the time. This was the only time that grew out some fungus. And so he was on an antifungal for a little while. This is his right side. Looks much, much better. Polyps are gone and just cleaning things out. So he did great, got back outdoors, and the real key is this is his sleeping quarters, and this is his little bed that's elevated about 6 feet off the ground. He gets up there by climbing on the fire hoses, and I knew he was doing better when Dr. Collins emailed me and said Vip was having gorilla-friendly relations with one of the females while climbing on the fire hoses last week. The aerial populations on a suspended fire hose is a great indicator of how well he is doing. It doesn't get any better for a male gorilla. And then just 2 days ago, I found out that Nadiri and Vip are pregnant. So that's a measure of success, and it couldn't have happened without these companies who donated all their resources to literally fly in this high-tech equipment to the Park Zoo and to allow us to do it. So that's my story at the zoo, and thanks for having me.
Thanks very much. We'll look forward to next year.
Have they tried with any of the stints to put an antibiotic in there with the steroid?
Not yet, but in talking to the company that's on their R&D plan. Okay. I did put stents in him, in the gorilla, by the way, because they didn't want to keep him on prednisone, and they wouldn't do death night irrigations. So we got I put the stents in.
Deathbed irrigation. I think you're right as fast as you can. Get on the other side of the window as fast. That's pretty cool. I wondered if that was...
I'm actually,